Thank you very much, Professor Yaqub, for such a very interesting presentation. It answers to most of our suggested questions that we are trying to answer in the next panel session. Usually, Professor Yaqub presents to us the most up-to-date evidence regarding any case and any problem that we face in our daily practice. When we were thinking to select cases to be presented in today's panel, we selected patients with poor responders because it's a very challenging case and most of interventions behind this case are away from evidence. This is why we are now trying to discuss this case in a panel, and we will try to find a solution from our great panelists. How are they dealing with these cases in their daily work and in their daily clinic according to the conditions and situation which is present in the Egyptian market. Okay, so I will start now by presenting a case of poor responder and some question regarding this case. Our today case is a 36-year-old patient with regular cycle. On assessment of the antral follicle count by ultrasound, we found only 2 to 4 follicles, and she's coming for ICSI due to male factor. So now we are asking Professor Yaqub about the investigation that he will request to this patient. Is he going to do any of this investigation before starting doing the ICSI cycle for this patient or not? Okay, Professor Yaqub, what's your opinion?
I think the English people would say the proof of the pudding is in the eating. لما تعمل طبق حلو تعرف ازاي حلو انه هو اتنسف. لو اتنسف يبقى حلو. لكن لو اتساب من غير ما يبقى نفس الكلام هنا. You have a patient who have 2 or 3 or 4 antral follicle, which means that she has, from the beginning, she has low infrastructure to support anything. What any of the additional tests you will do will add, will be stating the obvious, and will be telling you what you already know. However, if you are to do anything, I would suggest doing maybe day 3 FSH plus estradiol, because it will just categorize the patient on the road as far as ovarian function is concerned. If she has like 18 or 19, you know you really got to a stage where the patient needs to be counseled that it is nearing the end. But if it is still 11 or marginally, you just have a little bit of hope that you might get somewhere with ovarian stimulation, accepting that it will be very modest response.
Okay. So you, Professor Yaqub, saying that doing estradiol and day 3 FSH may have a prognostic point of view and may help us to expect the biological variation of the patient, as we have seen from the last slide by Professor Yaqub, that this patient in some cases may give follicles in cycles. So doing estradiol and day 3 FSH may help us to expect the patient maybe that may respond to stimulation later on. However, the rest of the investigation will add nothing, just only cost to the patient, and will not improve the management of this poor responder patient. The second question, this question is for Professor Hatem Abdelghaffar. Okay, if you are deciding to go forward for ICSI for this patient with poor responder, which one of the following add-on treatments you are expecting to give to your patient and may enhance the outcome of the cycle?
بص حقيقة حاتم كان دكتور يعقوب يعني قال في الأول في المحاضرة بتاعته we are not going to change the biology. Most of the adjuvant therapy in this country is, as I call it, political and not scientific. If I'm going to choose, I may choose coenzyme Q10 only, or nothing at all.
Okay, so the patient
we are confronted now, and all of those who are practicing IVF and ICSI, that most of our patients are coming to you with a list of drugs. Sometimes more than from 3 to 5 drugs, and they are part of the deal with the doctor. And most of the patients think that the pregnancy will be with these drugs, but actually there is no evidence for that. So I may choose coenzyme Q10 or nothing at all.
Okay. For the rest of the panel, Professor Yahya and Professor Sabri, Dr. Amr, do you suggest any other add-on treatment for patient with poor responder that's going to do IVF?
لا، بالنسبة لي أنا مش بدي أي حاجة من الحاجات دي، لكن لو المريضة قدامها شهر أو 2 على ما نبدأ بدي فوليك أسيد أند كوإنزيم Q10. إن جاست أنت تقول للمريضة ما تاخديش حاجة خالص، هي بتحس إن أنت مش مديها الاهتمام الكافي. يعني for me it's a psychological support rather than medical support يعني.
Okay. The same treatment. Okay, Professor Yahya.
No, I just would like to say that if you are to really under pressure of the society and the patient expectation to use something, you should always go for what is cheap, because at least you are using it as a placebo. You are using it to just satisfy the patient. I wouldn't personally use it, cheap or expensive, but the setting is different. So if coenzyme 10 is very cheap, I will use it. If it's not, I will not, because again, huh? العلبة ولا القرص؟ لا العلبة use it every day. That's fine. Why? Because when you read the pamphlet or the theory around coenzyme 10, it talks about the Krebs cycle and the increase in ATP that will increase the energy of the cell. All of that means nothing if there is no evidence in clinical practice that using coenzyme 10 will make a difference. But if you have to choose the lesser evil, the less expensive evil, then you can use. But if you touch growth hormone, ما عرفكش لا في الدنيا ولا في الآخرة. Okay?
Okay, Professor, I think the main problem that we are facing when we try to apply the evidence in our daily practice, we find many other factors in our communities that's facing our decision. Because some factors related to the finances, some factors related to the patient, some factors related to the other doctors who are saying wrong data. So you put all these factors in front of your vision when you are taking the decision to prescribe a medication or not. We know that it's not evidence-based and there is many data against, but we are facing all these other factors in our community that make some obstacles against us in applying the evidence on dealing with our patients.
I think it is a very peculiar situation that the patients are leading the treatment, not the doctor. Because they are coming. I always tell patients when they come to say, will you do that for us? I say, just entertain me. If you go into a plane when you are going on holiday and decide to just ask the pilot to let you run this plane, what will happen? Disaster. Okay? The same here. Patients do not know. They don't appreciate evidence. They don't know anything. They say, my friend has this treatment and it worked. We have no idea. Her friend may not needed anything. She may have been 28, who produced 15 eggs, who had 10 blastocysts, so had everything going for her. And I feel sorry for you, because for me it's easier. The patient will listen to what I say, or she has the whole world open to her. But here, I don't think you have the same kind of freedom, and the patient, usually, they don't come to us with the same misinformation. Yes, we have to contend ourselves with Dr. Google, who also mislead people, but it is much less taxing than being misled by fellow colleagues, doctors. Yeah?
Okay. So finally, to say all the add-on treatment on IVF, they don't have any impact on patient with poor responder. It will not going to improve the response of the patient. Actually, the difference is due to the biological variation in the patient and not due to any add-on treatment in between cycles.
The intervention proposed does not even make biological sense. Why would vitamin E has any role in response? Why would L-carnitine of all others have any role in response? We seem to be very imaginative.
Okay. So now we are going to the third question, and this question is for Professor Yahya. If you are going to select the ideal protocol for dealing with a patient who is poor responder, which one of these protocols you are going to select? You are going to prepare the long agonist, the short agonist, the antagonist, or the mini stimulation protocol with sequential collection of embryos and the frozen embryo transfer. Which one of them you are expecting the best response in this patient?
طيب هو for me الستاندرد اجونست والانتاجونست بروتوكول ممكن يدوا the same يعني comparable results. يعني اذا كان في بريفرنس الواحد عن الثاني ممكن مثلا لو انا شفت البيشنت في day 2 or 3 ولقيت مثلا الفوليكلز مش synchronized بستنى ابتدي معاها بالستاندرد اجونست بروتوكول. لكن لو لقيت البيشنتس في البيزل امورها ستيبل والفوليكلز سينكرونايزد ممكن ابتدي بالانتاجونست بروتوكول. فهم الاثنين كسكسس ريت ويل دو ذا سيم. بس في نقطه بالنسبه للمينيمال ستيميوليشن بروتوكول اللي انا ممكن انا انصح بيه او استخدمه في بعض الحالات لما تبقى فيري لو ريسبونس. لما انا ابقى متوقع مثلا الحاله ديت هتطلع بويضه او ما تطلعش خالص، فديت بعمل لها زي ترايل كده. لو طلعت 2 اور 3 اوسايتس بمينيمال ستيموليشن ممكن انا يعني لو واحده الاي ام اتش بتاعها فور اكزامبل 0.01 وانا شايف 1 فوليكل بس اور 2 فوليكلز في الاوفرز، يعني انا في دماغي مش يعني لو خدت التراديشنال اجونست او انتاجونست او خدت من ستيموليشن will end up in 1 or 2 follicles. فبختار المينيمال stimulation.
Okay, so if I understand well, you are saying that you are subcategorizing your patient according to their intrafollicle count. If she has a very low intrafollicle count, you are going to proceed with the minimal stimulation protocol. If she has a higher intrafollicle count, you are going to look for a synchronization. If the follicles are synchronized, you are going for the antagonist protocol. If they are not synchronizing, you will go for the agonist protocol. Okay,
yes,
so
thank you.
Anyone else of the panel have any opinion? Okay. Okay. Okay.
I think we are so romantic about synchronization. Whether it is short protocol or long protocol, you will always have follicles of variable size. So please remove that synchronization. It is a fantasy. And as long as you have 3 leading follicles in the standard program, the others will give you mature follicles if you aspirate them, mature eggs. So, and whether it is short or long, it might be visibly better with the long because of the suppression, but I don't think it makes any difference to the outcome. In the sense, all the analysis comparing agonists and antagonists have not shown any difference. Yeah? I think we are doing a lot of talking. We need to give opportunity to the audience.
Okay.
Please.
Just, okay, we'll open this, Professor Yaqub. What are you doing for this in Europe? Which protocol you are going to give patients with poor response?
I usually use standard, like I said, 2 to 5, F 150 minutes.
So
I know that I have
conventional
exhausted
protocol.
everything. Give her FSH, give her LH, give her recombinant, give her HMG. Cover all background. If she does not respond, I don't revisit it again. But if I use small dose, which is logical to reduce the cost and probably doesn't make any difference, if she doesn't get somewhere, I say, if only I give her higher dose. And then we start again.
Okay. So now it's open for the floor if one wants to add some comments regarding the ideal protocol that's going to be given for patients with poor responder. Any add-on comment for this point and for this question? Okay.
Mahmoud Shafi. Thank you very much for these comments. I would like to put 2 comments. One for the adjuvant therapy, from my point of view, as Dr. Yaoub said, nothing to do with this adjuvant therapy. And actually, if there is a message in this Congress, we have to point to our doctors, don't follow your patient. Because the patient coming to us offering us such a treatment, and we are following patients. Please don't follow the patients. Because the doctors just want to keep the patient at the clinic, but not treating them. Second, for the ideal protocol for poor responders, from my point of view, poor responders are poor responders, and all protocols at the end of the day may be giving the same number, we may be 1 or 2 follicles, but there is one protocol didn't get any popularity, which is the flare antagonist. Just start at the very beginning with 2 ampoules of GnRH agonist 0.1 with HMG, and then let the follicles grow, and when reaches 14, you can add antagonist drug. This had been tried, at least for myself. This is very good, but I cannot say that it's a life-saving for poor responders, but just a trial. But actually, as you said, both of them, at the end of the day, will not give more than 1 or 2 follicles or give nothing. Thank you.
Thank you very much. There is a recent paper in RBM Online discussing and comparing this protocol in comparison to the using the mini stimulation protocol, and they didn't find a difference regarding the number of the oocytes retrieved and the number of the embryos that are formed in between the two protocols. So it gives the same result like the mini stimulation protocol. Thank you. So now we are going to the next question. It's about the ideal dose and the type of gonadotropin that's expected to produce the best oocyte yield in this patient. And this question is for Professor Sabri. What's your opinion regarding this point?
In short, HMG between 300 and 450 يعني 375. You didn't put 375 HMG. This was انا كنت هدي العينه دي كده يعني. فلو انا هختار HMG between 3 و 4.
Okay, so you are recommending this patient to take HMG and you are recommending to give from 300
375.
to 450. Okay, so there is some debates in the literature regarding the type of the gonadotropin and regarding the dose that should be given in this patient, but they didn't find much difference in between the different types of gonadotropins, and even there is no much benefit with increasing the dose more than 300. So the maximum dose that can be given is 300. It produces the best effect in these patients. So I haven't read data regarding any benefit with higher dose than 300.
الحقيقه ليا كومنت حاتم بس على موضوع الدوزنج هي اللي هي من 300 ل 300 تو 375. احنا دلوقتي يمكن ايجيبت في الايرا اللي احنا فيها دلوقتي والدراجز غالبيتها نوت افيلابل. هو المفروض يعني يبقى في كاتيجورايزيشن للمرضى بتوعنا. يعني الفكره ان انا مثلا عندي واحده الاف اس اتش مثلا الاي ام اتش 0.2 او 0.3 والاف اس اتش بتاعها ما بين 15 الى 18. مش متوقع اكسبكتد ان البيشنت دي وات ايفر ان انا هزود الدوز في ان هو يبقى في انكريزنج في النمبر اوف فوليكلز. احنا بيتر في الايرا اللي احنا فيها ان احنا ندي 5 دايز اونلي ما نكملش يعني او ونشوف التست ريسبونس. يعني انا دلوقتي هديها 375 ولو زودت عن 1 ويك كله ده بيبقى ميجر دلوقتي واصله في البلاك ماركت في الايجيبت الاسعار صعبه جدا. فلو اديتها 5 دايز واشوف الريسبونس ما لقيش طلعت مثلا واحده نو نيد ان انا اكمل ب 375 يعني لو طلعت واحده كفايه 75 يتكمل بيها او 150 اونلي مفيش داعي ان انا اكمل الجرعه العاليه من ال 375. فانا شايف الايرا فكره ان انا بعض السنترز بيوصل 600 لدرجه ان هو يمكن عندنا في ابر ايجيبت الدنيا مختلفه. لا الوايف عندنا بعض الحالات اللي هي ما بين الاف اس اتش 15 الى 18 ما دخلناش في ال 24 بتاعت البريماتور ونبوز وجايه مثلا في السن about 30 وشي از trying. Maybe some of them try about 10 to 12 times and we at the center advise not to try again. She come again, not to try again and she come again. It is better in these cases to restrict to the minimum stimulation. Sometimes 150 in addition to clomiphene sometimes and it is enough for her. I think 375 is over.
Okay. I hear some opinions from some physicians, and this is for Professor Yaqub. They are speaking about the doses because most of the studies who are speaking about 300s are done in Europe and they're not in our community. And such patients are not having the same baseline criteria of our patients. So they may be sometimes, let's say, obese, and they don't have the same baseline characteristics. So if we are trying to adopt such guidelines, we should apply these guidelines to our patients in order to reach the optimum dose for our patients. Okay, so now we go for the next question. This is for Professor Yaqub. We need to know your opinion regarding the ideal trigger strategy for this patient. Are you going to give urinary HCG or recombinant HCG, and which dose you are using to trigger such patient to take the best oocyte yield?
There is no difference really between recombinant or urinary HCG. So that start with, you can use whichever available. Sometimes we say desperate situation require desperate measures. So we prescribe the agonist trigger for a patient who is on the antagonist so that she has dual trigger. Whether it makes a difference or not, we don't know. Really, it's just in desperation, you're trying to cover all grounds. In case it add one mature egg, you are a winner, but it's all consider judgment. And the good thing is the additional agonist trigger is not that expensive. That's all.
So, Professor Yaqub, you think that adding the dual trigger in this patient may improve the oocyte yield?
We don't know, but you just try, because as I said, you are facing desperate situation.
Yes.
And this is one shot that does not cost the head.
Okay. So anyone of the floor wants to add something regarding the trigger strategy? Anyone is prescribing different trigger protocol for this patient? So Professor Alam is going to present us this point.
Assalamu alaikum. First, I have to differentiate between two groups in poor responder people, the young groups of patients and the group of patients who are around or above 40. Because I felt from my practice that a better prognosis for these patients who are younger than 35 years. Because some patients come with poor responders, low AMH, high FSH, and they are 20 or 25 years. These patients, I think, have good or better prognosis than these above 40. This is the first thing. Regarding the trigger, I think 10,000 HCG is the ideal, and I don't think in adding agonist trigger with HCG, because I feel that this is as a detritus or determine non-good for increasing response. They has detritus effect, or what's called. So I think there is no difference between recombinant and the conventional HCG regarding the stimulation, the triggering. This.
Okay, Professor Alam, this is what is present in the literature. Really, there is no difference in between doses, and also no difference in between the different types of HCG that are used in such patients.
Hatem, we are running out of time for the next presentation.
So fast. Let's go for the next question. This is for Professor Hatem. Are you going to do fresh or frozen transfer in this patient?
Well, it depends upon a lot of factors, actually. If the patient, like Professor Alam said, the young patient, she is doing embryo collection. With the advancement of ultrasound and AMH technology, many young patients nowadays are coming with poor response with AMH less than 0.4 or 0.3 and FSH between 15 and 20. In this patient, I recommend to do freezing and embryo collection. But in some of the patient, if the patient is willing to do one cycle only, and she will not are going to continue, or the financial support is not good, I may do a fresh embryo transfer. It depends. It's variable. No single protocol is better than the other.
Okay. For the sake of time, we go to the next question. It's a very interesting question, and we usually face it in our clinics very often. A decision, don't try. Professor Yahya, at what time you are going to take? When you tell the patient she is not suitable for doing IVF. A patient's poor responder. When you tell her, don't do.
لو هي more than 43 وانا شايف بالسونار ما فيش فيها انترال فوليكل كاونتس وجايه بيريود اوف امينوريا مثلا 3 or 4 months، يعني مش هنصحها ان هي تعمل اي في اف او اكس. لكن لو يعني، وانا برضو ما بحبش ان انا يعني اوفر اي في اف او اكس اباف 43 في السيتويشنز اللي دي، الا بقى لو عيانه بقى هي اصلا مثلا عندها اولد بي سي او وانا شايف فيها الترا فوليكل كاونتس كويس، كويس بمعنى 3 4 she may try, but أنا I think إن ال success rate after 43 years whatever البروتوكول used أو ال number of embryos اللي احنا بنقولهم، برضه ال success rate is less than 10%.
Okay.
I have a comment on this. Our Professor Yaqub once said that if there is an menstruation, and FSH is this, then the the number of the menopause, you may try with counseling. Sometimes some of our Egyptian patients came to us. She has one male, and the male died due to an accident or whatever, and she come for the trial. He come for the trial between 43 and 45. In this situation, doing the FSH is proper. Doing the FSH is proper. If it is less than 20, you may try. Some of them are convinced that she will get a child. I have a patient 45 years, and she was coming with a big convinced that she will have the child, and she have the trial, and she gets the child. So hope is present. You give them hope, but controlled hope. So as long as FSH less than 20.
Okay, Professor Sabri, you want to add something?
يعني انا حاسس ان السؤال بس مش كاملان. Don't try to get pregnant و don't try to do IVF.
Yes, when you tell her don't do IVF. It's not
Don't try
going to succeed. Yes.
Don't try to get pregnant. I never told. Don't try to do ICSI. العيانه اللي فوق 43 دي I convince her to do IUI او timed intercourse, but not ICSI.
Okay, so we depend on age and antral follicle count to take the decision.
بقيه الكرايتيريا يعني كل الكرايتيريا اللي حضرتك كاتبها دي انا يعني convince them. I convince them not to do ICSI.
There are two sides to this. One is related to counseling, and the second one related to hope. Patients are prepared to be cheated, to be fooled, to be conned for remaining with hope. It is for us to give them the truth. If I have a patient, I had a patient the other day, she's a scientist. She was 46. She wanted to try. I told her, I've been working in this place 32 years. We've never had a baby above the age of 45. And even the 45 counts on the hands of one finger. Most of them will have miscarriage even if they get pregnant. So, are you still wanting? She said, I could be the one. And I would like to retain the hope. I said, I have cleared my conscience. I am happy to stimulate you. And she had stimulation, and the first cycle, she did not have any response. And that was that for me. End of story.
Even if she didn't have any antral follicle count.
No, it is. She has. Nobody will have. We'll always have one or two.
Yes.
Menopausal women have follicles.
Yes.
They have at least remaining 1,000. So it doesn't completely disappear. So she had what she had as long as you have not misled her.
Okay.
And that same apply for the 43, for the 41. As long as you are telling them, if I have a patient who's 43, I will give her no higher chance than 5%. You are making this substantial emotional and financial investment for the mere 5%. It is your decision, not mine. But don't blame it on me, because it's highly likely to go from this clinic empty-handed than otherwise. They pay for retaining the hope, for feeling that they have tried, before they go on to using donor egg somewhere else.
Okay.
Yeah.
Thank you,
I
Professor.
think we have no time
okay,
for.
we are out of time, so
We are going to
we are going. Okay, so we move to the next.
to the
panel
next
session. It's,